Dr. Patel will be the first speaker, and he will talk about peripheral arterial disease and the latest, and the greatest way to treat it. He's the chief of cardiology at Duke, and I heard he's an excellent speaker, and I was glad to have you here. Thanks to Med-Intelligence and for supporting the program here. And I would like to remind you that after he finishes, there will be, again, Dr. Jamil from Miami will be talking about pulmonary hypertension and right-sided heart failure. So you guys will have 2 for 1 tonight. 1 dinner and 2 talks, okay? All right. All right. All right, Dr. Patel. All yours. Okay, welcome, Dr. Patel.
Oh.
Any of you didn't have a voucher for drinks, please let me know. There's 2 bars available. Don't drink too much.
Thank you so much. And 2 talks, 1 dinner is probably better than 2 dinners, 1 talk, but depends on your perspective. So I have the opportunity to talk to you about peripheral artery disease. And to be frank, many of you know a lot about it because you've been probably faced with it for a while. But if the patients that you see with PAD are the patients I see in North Carolina, there's often a feeling of what can we do for these patients? And there's revascularization, anticoagulants, antithrombotics. How do we go? So these are my disclosures. It's important to recognize that I've worked with several of the companies, device companies, other groups that have participated in some of the research, and I'll try to highlight that when we're doing those things. I really have 3 messages for the talk tonight. The first is PAD is undertreated, it's missed, and has significant consequences. Now that sounds like an easy message, but let me just start by saying, if your patient has pain in their calf when they walk, do they take it as seriously as if they have pain in their chest when they walk? Do you take it as seriously as if they have pain in their chest when they walk? That's more complicated, right? Because it's a different workup and a different therapy. So I just highlight that that's an opportunity. Number 2, stronger antiplatelet therapy by itself, I'm going to go into this a little bit more, does not seem to improve the outcomes of these patients when we think about cardiovascular events. Now, how can that be? Because we've been very platelet-based in our cardiovascular care for a long time. So I do want us to think about that. What's not on my slide is maybe the hardest thing to do for our patients with PAD when they come in and say, it hurts my leg when I walk, is to say, well, you need to walk a little bit more. And it's really hard to do that. It's a little bit like Dr. Wagner's talk on rehab. How do you get patients training and working and exercising? And then I will spend a little time on some of the newer therapies that are being considered, some trial data that's now encouraging in peripheral artery disease, and some ongoing trials that we have in these patients. So this isn't new information. I'll call it the big 3: atherosclerotic heart disease, cerebrovascular disease, and peripheral artery disease. What's telling on this slide, which is now from 2013, is that we actually don't know the incidence of PAD. We know that there are patients at risk. We know that there are patients that have the disease potentially, but we don't have a ton of systematic disease sort of surveillance data. Maybe the most telling data now worldwide is this data from Jerry Folks, who's in the United Kingdom and Scotland, who showed us the global prevalence and risk factors associated with PAD. And this might just be thought of as the global prevalence of atherosclerotic disease. This conference is about prevention. You know the staggering statistics, maybe the biggest staggering statistics in the United States this year, according to the AHA Heart Facts that were just released, is unfortunately mortality from cardiovascular disease is going up. It's not going down. Today is go red for women and heart disease, and you know that for women and men, but certainly for women, it is the #1 killer, and it's greater than all the cancers combined. So if we're sitting worldwide thinking about vascular disease and its prevalence, we know that it generally is in all of the vessels: coronary, cerebrovascular, lower extremity. What's fascinated me for some time is why we have different phenotypic expression. You in the cath lab will have some patients that have horrific coronary disease and no PAD. You have patients with horrific lower extremity disease and clean coronaries with no calcium. and some people that'll have an overexpression of 2 vascular beds but not 3. Now, there are some reasons we can think about that, but as you think about our therapies, we use all of the same therapies, understandably, for all of those conditions, but there may be differential effects based on what those patients have. What's the other thing that's really notable about the world right now? What's the average life expectancy for a man in the United States today? Do you all know? 78, 79, and a woman is a few years older, rightly so, probably about 80, 81, 82. 10,000 patients every day become Medicare eligible in the United States. The burden of taking care of these patients in an effective and cost-effective way for prevention is going to be critical. Diabetes is unfortunately growing at a staggering rate. Obesity is growing at a staggering rate in the United States. And in parts of the world that aren't the United States, when you think about even sub-Saharan Africa, you look at Southeast Asia, you look at the prevalence of PAD in 30 to 35 to 44-year-old people in some parts of the world, where these diseases of what I'll call cardiometabolic vascular footprint, staggering population worldwide. It's estimated based on this paper that about 200 to 220 million people will be known to have PAD. So what are the natural history and outcomes? This is not extremely new information, except that I would say what we're learning in the most recent data is that it isn't an arrow. Like the guidelines show us, people have fatigue, maybe some claudication, rest pain, poor wound healing, maybe gangrene, what we'll call claudication to limb-threatening ischemia. In fact, patients go back and forth. Half of the PAD patients may not have a symptom that we know of. They may have atypical leg pain. As you know from now the famous Alan Hirsch paper and others in the New England Journal and in JAMA, about 7,000 patients in Boston were evaluated with an ABI in general practitioners' offices. Over 70-year-old patients or 55 and over with diabetes, and 28% of those patients had PAD, and only 50% of the physicians knew those patients had PAD. So our ability to recognize that, and the large campaigns of getting our patients shoes off, socks off, feeling pulses in the leg, trying to ask about those questions are important. But what we also recognize, and Mary McDermott has championed this, that maybe the best measure for patients is a simple measure, a 6-minute walk test, a total ambulatory time or space. The 6-minute walk test is getting used more and more. I do like, I will say, ABIs from a physiologic perspective, and I'll show you some data about that. Feel free, by the way, to raise your hand, scream out a question, ask for a drink ticket. Happy to help with all of those. So if we thought about peripheral artery disease from our patient's perspective, their biggest concern usually is around functional capacity and quality of life. We worry a lot about myocardial infarction, stroke, death. They care a lot about amputation, tissue loss, and the ability to ambulate. If you ask patients in clinic, what is it you're most worried about? It's I want the pain to go away. I want to be able to walk farther, keep up with kids, grandkids, other things, go to church, go to the mailbox, or I don't want to lose my leg. I don't want to have an ulcer. Certainly, most patients don't want stroke or all these other things, of course, but MI is not high on their list when you talk to them about peripheral artery disease. These I would call patient-reported outcomes that we know well, and these are our clinical outcomes. So here's the burden of atherosclerotic heart disease. This is the 10-year data from Michael Cricky and others that's published now, some 10 years data. If you have peripheral artery disease, you have a 4-fold increase in having cardiovascular MI, and then you have a 2 to 3-fold increase in stroke. What's not on this slide? This tells you how cardiologists have been thinking for a long time. We're just starting to think differently. So what's not on this slide is we tell you, if you have a leg vascular problem, we tell you how your brain or heart do. If you have your heart problem, we tell you how your heart or brain do. If you have your brain problem, we tell you how your heart, brain do. None of them do we ask you how your leg does. So we've been for a long time saying, well, if you have it in your legs, we got to worry about your heart and brain. But we haven't been saying, hey, if it's in your heart and brain, we should be worrying about it in your legs, right? And when you say you should be worrying about it in your legs, well, of course, it's a symptomatic problem. Although more recently, when we look at our trial data, what you'll find out is that even patients with just coronary disease and stroke and no known peripheral artery disease are having rates of amputation, acute limb ischemia, and atherosclerotic events in their limbs that we might not have attended to. So, what's the chance your patient has one of those things happen? This is Mary McDermott's data that says one of the things patients do, I call this the Walmart test in North Carolina. As they start having more pain in their leg, they go slower and slower down Walmart and lean on the cart more. Don't walk as far. Don't go to the mailbox. When you ask them how are they doing, they go, I'm still doing fine. I can still go there, do the things I want to do. You have to probe a little farther, say, well, how far do you go? Can you get all the way as walk as far as you used to? Do you have to stop? Do you have pain? It's a lot like an anginal questionnaire. It's just what people often find is that claudicants and claudication patients slowly self-limit their walking distance because of pain, and they don't train because of the pain and the dysfunction, so there's a functional decline. This is message number 2. I think you guys probably have this message too. Patients with peripheral artery disease, unfortunately, they're undertreated, and they have poor outcomes. So this is a paper a fellow of ours did. One of the first therapies that were recommended in the guidelines for PADs is aspirin, an antiplatelet therapy. And the problem with understanding if people get aspirin in the world is because in the United States, you don't prescribe aspirin, you get it over the counter. But in Denmark, every medication is a prescribed medication, including aspirin, with a very clear record of where patients go. It's not the perfect record, but it's probably about 95% right. So we did an analysis, and we called it missed opportunities. We said, what's the chance of getting an antiplatelet therapy, a statin, or an ACE inhibitor if you have coronary disease alone, PAD with CAD, or PAD alone? In Denmark, now it's Denmark, they actually are very regimented about what they do with their cardiovascular care. So if the chance or the hazard ratio is 1 to get an antiplatelet therapy, a statin, or an ACE inhibitor with coronary disease alone, with PAD, it was 0.4 for aspirin, 0.45 for statin, and 0.4 for an ACE inhibitor. This was published in 2012, 2013. We hope it's better, but it just highlights. Now, when you add CAD to PAD, you got that rate for an aspirin up to 0.8, but you still didn't have a very high rate for statin. Now, one would say, well, Manesh, you know, you're telling me about undertreatment. A lot of patients get undertreated. But I showed you data that if you have PAD, it's probably equal to diabetic risk reaction for having cardiovascular or stroke events. This is more recent data, so you would say, okay, well, that's not the case. And this will maybe a little out of focus for you. I apologize if it is. Jeffrey Berger published this in JACC, looked at outpatient therapy, and this is antiplatelet, this is statin, ACE-ARB, cilostazol, exercise diet, and smoking cessation. Red is PAD plus CAD, blue is PAD only. If you just have peripheral artery disease, we don't use the same level of stringency on trying to get your medical therapy to where it should be. So I would say, again, an opportunity to treat. Well, what's this map? This isn't the polar vortex. This isn't the heat map. This is, unfortunately, I live here, Durham, North Carolina. This is the amputation map of the United States. We published this in 2010. And what do you see that is unfortunately true in the United States today? The hypertension map, the stroke map, the diabetes map, the obesity map, the amputation map all seem to be in very specific areas, overrepresenting the Southeast United States, overrepresenting rural communities, overrepresenting access to care. Unfortunately, this is what we must change. We have to, I now say in our institution at Duke or others, we have to change the map. We have to discover and deliver care better to change the cardiovascular outcomes. Now, if you don't believe you can do that, I don't have the slides to show you the map, but the map looks the same for acute MI, except once we started doing regional ST elevation myocardial infarction care with sites randomly and fastly getting patients to a STEMI center and doing standardized post-MI care, we reduced the mortality in the places that have STEMI centers by 20% in our area. In this map, age, chronic renal insufficiency, and the county you live in were the strongest predictors of having an amputation. So imagine that I live in Durham, North Carolina, Henderson, up towards the Virginia border. I know we have colleagues from some of those areas. As you get closer to certain parts of the country, because of access, because of a variety of social determinants of health, your chance of losing a limb is fourfold higher than just 40 miles down the road. Now, all of that's not going to be fixed with an aspirin prescription or a statin prescription by any stretch, but a lot of it is going to have to be dealt with as we start to think about the community. This is another paper that one of our fellows, now faculty, published. This is called, we took Medicare and we said, okay, let's look at everybody who had an amputation in Medicare and say who had an arterial test before they had an amputation. An ABI, if that was billed for, an ultrasound, a CT. What can we see that the care is? 30% of people who have an amputation in the United States do not have any testing to see if they have arterial disease before the amputation. Let me say that again. So 30% of people who have an amputation in the United States, this is 2014, so yes, we're 4 years later, but we'll have to see if we're much different, do not get an arterial test before they have an amputation. They have an ulcer, they go to a wound center. Remember, once you have an ulcer, if you have PAD, it's really hard to move. It's really hard to get farther from your home. You go to the local wound center, you get the closest vascular specialist, who then makes a decision about any testing or amputation or debridement or surgical care. So the most likely test was an ultrasound followed with an ABI up here, an ankle brachial index. But it's just to highlight to you that we don't have standard ways in which we care for patients with PAD. And as I said at the start of my talk, if you had chest pain, we would be very quick to make sure we understood what was causing that. If you're a diabetic with an ulcer on your toe, we're not equally quick to say, what can we do to make sure that that is being heralded as the same thing? Okay, so I told you that there's a lot of PAD. PAD happens in the United States worldwide in places where there's a lot of sort of geographic variation. And then I told you that they're not all getting the same level of care. And then finally, unfortunately, I told you that we're not testing them as much. So then what happens if you have an amputation from PAD? This is again from Medicare, so it's a bit. One of our publications now, I think this is from 2013. If in Medicare you have an amputation, so you're in Medicare, so you have to be 62 to 65 years old, so it's a bit of a population of people older. If you're 62 to 65 in Medicare and you have an amputation, your all-cause mortality, your chance of being, unfortunately, dead at 1 year, PAD with the lower extremity amputation, 1 year, 48%. Staggering, right? Any type of amputation. This is a major amputation, I should be clear, it's major, not any. So major means it was above toe, right? Above transmet, so it's got to be at ankle or above, not just a toe amputation. But if you're a patient in Medicare, 65 or older, and you have an ankle level or higher amputation, 48% chance you've passed away at 1 year. 30% don't get a test, 48% have an amputation die at 1 year, 50% of them are getting an antiplatelet or antithrombotic. Overrepresentation of areas where we don't have care. So I didn't do the slide. We have a talk on death and disability and quality adjusted life years at risk. But if we were to say how many meaningful quality life years for our patients that might be at risk for this disease could we be affecting? As cardiologists, as cardiovascular specialists, it's certainly something we could focus on. All right, so I spent the first 10, 15 minutes hopefully getting you through your early part of dinner into awareness around PAD. And it would tell you that at this point, if there are any questions before I go into the medical therapy around PAD, I'm happy to answer those before I go on, but pretty staggering data. I'm sure there's some. Yes, sir. It's a great question. And I think it's a relative, let me see if I can get there. Yeah, so it's really interesting that Florida seems to stick out. People would say that for a lot of reasons in Florida, I guess, but I'd say Florida does really well. And why is it sticking out? We don't know for sure. We think that there are at least probably some better care processes potentially. Don't know for sure. We do know that the map in general, even in the state of North Carolina or in the middle of the country where there are mountains, there's less PAD because patients with PAD don't get into higher regions. It's really hard to get into Colorado and be a patient with bad PAD. Not to say it doesn't exist there, relatively less. Florida actually does a little bit better on the hypertension diabetes map, but we don't know for sure why so much of Florida does better on the PAD map. There is certainly an amputation thing. The other thing I will tell you, I think some of this is a relative issue, right? There's still patients that are having amputations at 1 per population amount. It's just that such a density of it in this region. Okay, I'll go to the back and then come to the front. Yes, ma'am. Yeah, so just so everybody heard the question, I'll repeat it, was are there any blood test prognostic indicators, homocysteine, LP(a), CRP, a variety of those? It turns out almost all of the patterns that we see with atherosclerosis, we do see with PAD, but we have a lack of data with longitudinal large amounts of data. I'm going to show you a large trial or two that we've conducted where we started storing the blood to look at it. I would say most of the data I've seen with CRP or any of the inflammatory markers seem to clearly be elevated in patients with PAD. Of course, we've also been very focused on the physiologic ABI test, and obviously that's not a perfect test because calcified vessels are non-compressible. So even within that, there's some issues, of course, for diagnosis. I don't spend a ton of time on the PAD diagnosis, but I would say, obviously, the ADA and the guidelines would say certain patient populations, those over 70, those over 60 with diabetes that might have cardiovascular risk factors or discomfort would be high quality screening, or at least patients you would look at. I had 2 more questions. I'm going to come in here. Yes, sir. And then
yeah, the question is, there any whereby applications will not be involved unless you have some.
we are trying. Yeah, I've tried to, we've tried to be advocates, just to hear the questions that everybody heard it. Is there any legislative or health policy efforts in which you cannot get as reimbursed as well for an amputation if you haven't done some sort of arterial evaluation or something like that? And we have advocated for that in North Carolina, and we're advocating that on a national level. I'm not sure it will happen, but certainly I think it makes a lot of sense to say if there's a non-invasive test that doesn't cause any, doesn't need an IV, doesn't need contrast, doesn't need radiation, and you could do it on your patient before they had to have an amputation, even if it just told you where the level of the amputation should be, should we be considering it? Now, some of the data could be skewed in that people might be doing it in their office and not billing Medicare for it. I hear that at some conferences. That's possible. I think that's less likely, I will just say, because most of the things we do in clinical practice, we figure out how to bill for. I'm sorry, let me get to her and I'll come to you. Sorry, just she'd been waiting for you. I'll come to you next. Sorry, I'm going to go to her and then, great, yeah. I think if you can get an ankle brachial index, in most patients, that's the #1 test people will say. And remember that, just to remind for everyone, that's a blood pressure in the arm and a blood pressure in the leg with a pulse pressure. Now, you may not have a Doppler to check it, so you can send it to a vascular specialist. But in general, I tell patients all the time, if your blood pressure is 100 in the arm, it should be 100 at your ankle. In fact, with gravity and other things, it should be 110. But let's say we're going to give you 100. And if it's less than 90, 0.9 ABI, then it's going to be abnormal. When it's 50, I'm telling them, look, 50% of the blood flow somewhere between your heart and your leg is gone. And that's 50% of blood flow differentially. All right, I'm going to come to you and then you, sir. So I'll say his question so everybody can hear it, and then I will. I don't know that I have an answer, but he said, "What's going on? I've been retired for 10 years, but this is sort of what the data look like. This is appalling. What's going on?" And I think the awareness of all the things that are out there to care for, vascular disease, heart disease, a lot of things to care for. I think there hasn't been as good a advocacy, science, and other things, and of course, health policy. There's not a clear message of how we can manage these patients with a pathway. There's guidelines, but I think I will also say today, I'm going to talk about some therapies. Sometimes you need effective therapies to infuse ways in which you can find the patients to treat them. And we have effective therapies. There's statins and blood pressure, diabetic control, but one might argue that was supposed to be done to everyone, and these patients might be losing through that. One more question, and then I'll get into the second half. Okay. All right. Sure. No problem. So what about the biology of atherosclerosis or atherothrombosis? This is a review we put in for PAD and JACC, and as you all know, there are these nice central figures you can now have, or many of these journals have, and I think they're useful. So I would just say there's been sort of a biology of what I'll say the current cartoon of how we think about the biology of thrombosis, right? And there's sort of two big pathways. There's what I'll call the platelet activation pathway, where we have these receptors, P2Y12, or clopidogrel, prasugrel, ticagrelor, IV Canglor might work. A PAR1 receptor, where vorapaxar might work. We know it works. Thromboxane, where aspirin works. This activated platelet interacts with thrombin, and that can then lead to fibrin, leading to a clot. And then, of course, there's the disruption, and I don't have to tell this audience, a lot of people have been thinking about these things for many years. Disruption of the vascular endothelium and the clotting cascade, which right now, through activated factor 10A, is inhibited by a variety of direct factor 10A inhibitors, rivaroxaban, apixaban, edoxaban, betrixaban. The bigatran's a direct thrombin inhibitor, and these then interact to potentially stop this. So you can imagine, with the influx of fantastic therapies, these antiplatelets, these 10As, there's a lot of studies that have been done on the brain, the heart, the limbs. So how do you put it all together? Where are we with all that? How does it work for PAD? And why would we get differential things? For many times, as a stent doctor in the coronary artery, I would say when you disrupt actively the vessel, platelets seem to have a very large and important effect. Long term, that plays a role, and then probably 10A has a role, at least on venous embolism, arterial clots such as atrial fibrillation, and then we can talk about PAD today. So antiplatelet therapy for PAD, I'll just, without going through every single one of the slides, I'll sort of give you the top line, if you will. Aspirin is mildly better than placebo. That's based on a meta-analysis, best case scenario of about now, I would say, I think there's about 2,000, 3,000 patients. This is in light. I made this slide, by the way, before the most recent AHA, where we had the aspirin primary prevention trials, where we can think about aspirin as a cardiovascular prevention agent. This is specifically about aspirin for PAD. Capri, now 20 years old, showed that clopidogrel was slightly better than aspirin in a broad vascular population. When I say slightly, I'll tell you the numbers in a second. But that was about 20,000 patients with either coronary disease, peripheral artery disease, or prior stroke. They got randomized to aspirin versus 75 milligrams of clopidogrel. They followed those patients for cardiovascular death, MI, or stroke, and those events happened roughly about 5.5% in both groups, 8% relative risk reduction with Capri with the clopidogrel that was statistically significant. So that's the aspirin meta-analysis. You probably can't see it from back there. That is the now Capri data slide that I just showed you, an 8% overall risk reduction. Just remember, though, that this is 5.83 versus 5.32. So a 0.5% absolute risk reduction, important, but one would say you'd have to treat several hundred patients to get that effect over a few years compared to aspirin, and probably didn't take off early on because of the cost of clopidogrel compared to aspirin. Now clopidogrel is generic. And then what about two drugs versus one? Aspirin and clopidogrel versus aspirin alone. And that was tested also now 15 or more years ago, 20 years ago, Charisma, which took a broad population of patients with coronary disease, vascular disease. Now, they actually included diabetic high-risk patients. So those patients didn't have known coronary disease, and that lesson might be getting recapitulated with the most recent aspirin trial, prevention trial. Placebo and aspirin, the event rate was 7.3. Clopidogrel and aspirin, the event rate was 6.8. Just because of the size of this trial compared to Capri, that was not statistically significant with a p-value of 0.22. And the bleeding with the two drugs versus one at that time, there was a fair bit more moderate gusto bleeding. And so the guidelines then and now for PAD recommend monotherapy, one antiplatelet agent for patients with PAD, whether that's aspirin or clopidogrel. That's your choice. There's that difference, but they don't recommend two drugs versus one. Now, I say that with the knowledge that if you came to Duke University and looked at some patients with PAD, you'd find some on 2 drugs. You find some all over the country with 2 drugs that have PAD. And that is mainly because we're thinking a lot about heart disease and thinking, well, we think DAPT is good for coronary disease, so we're going to try to treat our patients with PAD for that. And then I participated in a trial called Euclid, where we took 14,000 patients with PAD, and we tested ticagrelor versus clopidogrel, and published this in 2016 with the idea, again, that in this, I sort of ambulatory, outpatient, mostly claudicant, but some CLI patient group, they got a stronger antiplatelet agent. I would not argue that ticagrelor is clearly stronger than clopidogrel in most places. And everywhere we see it, it does better. But without aspirin, just mono a mono, it looked pretty similar for the event rate of death, MI, and ischemic stroke in these PAD patients. Now you'll notice we went out to 2.5 to 3 years, and the event rate's not small, it's 12.5%. These patients are still having events, it's just they were not having a reduction with ticagrelor. And celestazol, which has some, good question, so somebody's asked about celestazol. Remember, celestazol in randomized trials, about 300 to 500 patients, has been shown to make you walk farther. It has some mild antiplatelet agents. In those trials, it was allowed as a background therapy. In practice, it was used less than 5% in these patients. It's not used much. There's some gut intolerance. It costs some money. Patients. I'm sorry you can't see that as well. I apologize. Basically, these are the guideline recommendations for patients with lower extremity PAD, class 1A, and antiplatelet agent. They either say aspirin or clopidogrel to reduce MI. They don't tell you to choose which one. And then they go through a version of this. I'll just say dual antiplatelet therapy, 2 drugs, is a 2B, not a 2A. It's a 2B recommendation. So most of your patients with PAD, unfortunately, the other reason their therapy is supposed to be an antiplatelet agent. And a stronger one didn't seem to beat, and 2 didn't seem to beat 1. So it's a confusing space, right? So that's why I would say that the evolving world of antithrombotics and some of the data with the 10As that I'm going to show you now are encouraging us and making us think about how do I think about the space. Now, I didn't show you back here one other agent, vorapaxar. That was the clinical benefit of vorapaxar. That PAR1 inhibitor has been shown in TRA2P to reduce not only cardiovascular events, but amputation and limb ischemia in patients who had coronary disease. But that was on top of existing antiplatelet therapy. So they did add that agent on top of aspirin, or aspirin and clopidogrel, or clopidogrel. So it was the second agent. There, that second drug did seem to improve limb benefit, but there was a bleeding risk to pay, and so people have to balance that if they're going to use that. That drug did not get a lot of uptake. I believe one thing I haven't talked much about are those patients who undergo peripheral revascularization, where we do a stent or anything like. In that population, I think there's an opportunity for that therapy to be beneficial, but would have to be tested. Okay, so what about the new drugs and things? So first from Euclid, the trial I just told you. The other thing you should tell when you're in clinic, how do you know who somebody's really high risk? How do you know? Age, diabetes, what else do you know when somebody's really high risk for having events? The number of vascular beds affected. The patients had a history of a stroke and they've had a heart attack, or they have claudication and they have coronary disease. So this is basically, Deepak Bhatt and others have made the term polyvascular from the REACH registry, something we've used. This, in Euclid, we said, well, what about the other way? What if you had leg disease as the background for everyone, and then you added on heart disease or stroke or cerebrovascular disease or all 3? And so this is the event rate, and you can just see that if you have PAD alone, if you have PAD plus CVD, the brain, if you have PAD plus heart disease, and then if you have all 3, you do really poorly. So what you should learn is polyvascular disease is bad. Not so hard to know, but it's worth thinking about. So the same illustration I showed you before, we think about that and how you would do that. So I told you so far that the guidelines recommend one of these agents, a little bit of vorapaxar. How about here, have these been tested? And so that's part of the talk conversation is this trial called COMPASS that took 2.5 milligrams of rivaroxaban plus aspirin. I got to be honest, when this trial was started, I thought, do we really need to add a low-dose anticoagulant on top of aspirin to patients with coronary disease and PAD? Like, is that going to work? And so over 20,000 patients looking for 2,200 primary events out to 3 years. They had asked me, I was on the other trial, and I said, I'm not sure it's going to work. You always a healthy sense of skepticism. They randomized them into one of three groups: aspirin alone, rivaroxaban 5 twice a day, 2.5, the very low dose from Atlas twice a day, plus aspirin. And here are the findings: CV death, MI, and stroke. The trial, first I should tell you, was stopped early for a mortality benefit, a cardiovascular mortality benefit, event rate by the DSMB. We can look at the data carefully to say, did they stop it on purpose? Both rivaroxaban arms were winning when they stopped it. When they got all the data together, the rivaroxaban 5 by itself versus aspirin wasn't that different, but the rivaroxaban plus aspirin versus aspirin continues to change its curves. I'll show you the data more specifically and easier to see. So these are the components of the statistically significant primary endpoint. CV death was reduced by 22%, stroke was reduced by 42%, MI by 14%. Some of these are lower than 1, some are higher than 1, but the composite was clearly much lower than 1 and stopped. Pretty powerful, I think, I would say. But interesting to me in that the stroke reduction in this patient population of vascular patients, some of whom had carotid disease, not AFib. There were not AFib patients encompassed. They were patients with vascular disease, coronary disease, or carotid disease. Had that benefit. And the secondary endpoints of ischemic stroke, MI, acute limb ischemia, death from cardiovascular events, again, just continues to show difference. And then when you get to mortality, death from any cause is 3.4% versus 4.1%. A 0.7% absolute risk reduction that is clearly bigger than what we saw with those antiplatelets, and a pretty much what I think they used to stop the trial. How about the CAD group versus the PAD group? Because some patients came in with PAD versus CAD. All of the PAD patients, you should know, most of them had coronary disease too, so they're probably polyvascular. The first thing you see is PAD patients had much higher event rates. Aspirin patients had a 6.9% rate versus 5.6%. And the hazard ratio was similar, if not better, for PAD patients. How about bleeding? We don't get anything for free, right? You give somebody more of an anticoagulant, you might stop some of this, but you might cause some of that. And I think it's important to recognize their major bleeding definition, which was an ISTH major, one of the definitions that most of the trials used, but it was a little modified, maybe a little more sensitive. It was increased significantly with rivaroxaban plus aspirin, right? It's a 1.7 hazard ratio, 3.1% versus 1.9%. So about a 1% absolute risk increase in major bleeding. A trend, but not much different in fatal, not ICH, not critical organ. So a little bit of help there in making you feel a little bit more comfortable potentially. How about the limbs, the legs? This is potentially why I was interested in the trial more than even the heart data, because I showed you all the things happening to people's limbs, how we don't have a lot of things to do for them. This was now 2017 presented there. Even though small numbers, a significant reduction in major amputation, a significant reduction in patients with major adverse limb events, having to go to the cath lab for acute limb ischemia, having to have a major procedure, surgical procedure for their limbs. So I would say, you know, very encouraging. Only 50 or 60 events totally, I get that, but very encouraging in that you're going to get a pretty strong signal in a large group of patients. So now I talk to you about these agents. I just showed you low dose of this plus aspirin might be something that had an effect. One might argue was ticagrelor plus aspirin versus aspirin a thought, a low dose one, but there was all these conversations in that space around aspirin with ticagrelor. So one might say there's some constant information there. I didn't show you Pegasus, which was ticagrelor plus aspirin versus aspirin in chronic CAD. There was a limb signal. So you do wonder, is there some mixture with aspirin that is needed? So I'm going to stop with some conclusions and then see if you guys have some questions. What did I cover today? PAD is common. They have a high risk for events and they're undertreated. I'll call it dual pathway. Rivaroxaban, 2.5 milligrams with aspirin. So dual pathway, both the platelet pathway and the what I'll call the thrombin pathway, if you will, seem to reduce MACE, male, and amputation in patients with CAD and PAD, and certainly the PAD patients are of interest to us. And there is an ongoing trial, which we're participating in, others are, looking at patients who get a peripheral procedure that get this regimen of drug plus aspirin versus aspirin to see after a peripheral procedure where we see a lot of events, will that really help? And I will say that this agent and this, at least regimen, if we can start considering it and using it, not just to give it that to the patients, to lift all boats, get them with statin therapy, reduce their blood pressure, get awareness about walking, Sometimes when they're active agents, we can do quality improvement projects for our PAD patients, which will certainly help, I think. We still have a lot to learn about perfusion of the limb. We have a lot more to learn about how these patients are identified or why certain vascular beds are affected, but hopefully we'll learn that. Let me stop there and thank you for your attention. I appreciate the opportunity.